Thanks, Kelly. So many of you I know. I'm Laura Lander, social work faculty in the Department of Behavioral Medicine and Psychiatry. So glad to see so many people here. I think we got 38. That's good number. Today I'm building a little bit on a presentation that I gave in November on the SUD echo, which was the impact of substance use disorders on the family. And this is going to be really focusing on a particular evidence-based intervention called CRAFT. And I'm just curious, like, how many people are familiar with the family intervention CRAFT? Just you guys can put your hand thingies up if anyone's heard of CRAFT. I'm not seeing a lot of hands. Oh, Jeremy. Okay. All right, so this will be new for most people. So I'm going to go through it in as much detail as I can, and then there's some resources at the end of the presentation for people who want further training, because this is usually a more extensive training. This is really just kind of exposing folks to the model. So I'm going to share my screen. Everybody see that? Okay, great. All right. So we're going to talk a little bit about, I always kind of like to put these things in context. So the prevalence of substance use disorders and the family members that are impacted. We'll talk about the CRAFT model, which stands for Community Reinforcement and Family Training. We'll go over the key goals and we'll go over the evidence basis, but we'll go over the model in some detail. So in terms of substance use disorders and the family, this is a national survey on drug use and health data. So just to kind of put it in context, 48.7 million people in the US age 12 and older were diagnosed with a substance use disorder. And you see the alcohol and drug use disorders broken down there. And only 1 in 4 adults have identified as having a substance use disorder received treatment. And so it always comes to mind why. Sometimes that's about access, that people don't have access to treatment. There's no treatment in their area, certainly in rural areas. We know there's limited treatment. We're working on expanding that and have been trying to do so for many years with our SOR program. And other kinds of trainings, including ECHO, so trying to get more people comfortable with treating substance use disorders. As many of us know, part of it is when people have a substance use disorder, they don't always identify as having a substance use disorder, or they don't have a desire to quit. Oftentimes what we'll see is the individual themselves may not be ready, but their family is significantly impacted by their substance use disorder. So 2/3 of Americans report they have a family member with a substance use disorder. That is an enormous amount of people. And oftentimes family members are identifying it as a problem, the use of substances, whereas the individual using substances either doesn't see it as a problem or isn't interested in seeking help for it or quitting. And so this is a large group of people when we think of the number of family members who might benefit from treatment themselves, even if their loved one does not want to seek treatment. And 1 in 5 children grow up in a home where someone misuses drugs or alcohol. And so we see this ripple effect on children, on families, and it goes in both directions. It kind of, when we think of generations, it impacts parents, it impacts grandparents, and it impacts children's aunts, uncles, cousins, and the whole family. So when we think about systems theory, the CRAFT model really is built on the foundation of systems theory. The primary assumption being that individuals with substance use disorders are members of a family system, and taking a system perspective actually facilitates effective interventions because different parts of the family system influence one another. So if mom makes a positive change, it will influence other people in the family, including potentially a daughter who may be using substances. And the other kind of foundational tenet is the physical and mental health of family members are negatively impacted by a loved one's substance use, and family members really need access to treatment too. So the CRAFT model was created by Robert Myers and Jane Ellen Smith, University of New Mexico, and it grew out of the community reinforcement approach, and it integrates certain components of that approach. It has been adapted for groups, so it can be done with families, with individuals, or with groups, which I think is really one of the strengths of the model. You can adapt it to different modalities. And it's also shown, evidence shows that it works with adolescents or adults. So if the individual with the substance use disorder is an adult or adolescent, it works equally well with those family members, and it's evidence-based. This is the manual. I just wanted to show a picture of the manual. So that's kind of the basic text for CRAFT. And it's not too thick. It's not too complicated. And these are some key terms that I'm going to begin to use just because it's a little bit easier, and the model utilizes these terms. So CSO stands for concerned significant other. So that's the family member. Identified patient, we often talk about as the IP. So that is the person who is actively struggling with substance use disorder. And then, as I explained before, community reinforcement and family training is what the CRAFT model stands for. The primary goals of CRAFT are to help the family member feel better. So that's whoever is coming in saying, I have a loved one who has a substance use disorder and I need help. That can be one person, that can be 3 people. It doesn't matter. Any number of family members are welcome into treatment with CRAFT. One of the other goals is to reduce the substance use in the identified patient. So that is always the family's goal. And interestingly, in contrast to family kind of peer programs like Al-Anon, that is not one of the goals of Al-Anon. So Al-Anon basically says that you're not going to make your loved one stop using, so you need to really focus on yourself. This particular treatment intervention has a different goal, which is really to reduce the IP's substance use and to get the IP into treatment. So 2 of these goals are very focused on the identified person who has a substance use disorder, which is a little bit different than like what peer programs typically focus on for families. And some key concepts that family members have a really important influence on the IP's motivation. Often they have leverage that treatment providers do not have, especially with young adults who may still be living at home. That family really has a lot of influence, or adolescents over that individual. They have a lot of contact with the person with the substance use disorder. They have a lot of information about the individual's use and those patterns and those interactional patterns, as well as the use patterns, and they have that leverage. So family members are considered really crucial collaborators in treatment. And family members need help too. So we know that family members get both physically and emotionally sick, develop mood disorders, and even post-traumatic stress disorder symptoms from living with someone who is chronically using substances. It's like living with someone with a chronic illness. It's a pretty big burden for family members, especially if they're living with them. If they're not living with them, it's slightly less stressful, but there's often enmeshment between family members. So typically, family members are looking to fix their loved one. The structure of CRAFT is 12 sessions. It can be group, individual, or multimodal, so including family. It's very behavioral. So this is not a processy kind of model. Very behavioral. It's really all about behavior change. It's person-centered, non-confrontational, very active. They're like CBT. There's homework assigned at every session. In the beginning of the session, you go over that homework. If the person didn't do their homework, you basically do the homework in session. So it's really structured and takes into consideration potentials for violence. There's a whole component, and I won't get into it a lot today, but sometimes when family members change their behavior, their loved one who is actively using substances in order to get their needs met may respond with aggressive behavior, threats against self or others. And so this model does consider those concerns, which I think is really important because we see that happen. Any questions or comments up to now? Kind of just the basics. Okay, I am happy to be interrupted with questions if there are any in the chat or any comments people have. So I'm going to go over the core procedures, and I have some handouts that are typically given to patients who are coming in that involve these procedures, and I'll show them periodically as we go along. Not every single one has a handout, but these are basically over the course of 12 weeks, these 9 procedures would be how you structure your 12 sessions. So the first one is motivational induction. Again, family members can seek this treatment without their loved one. And that's typically how it's set up, is that the loved one does not actually participate, the loved one who has the substance use disorder doesn't actually participate in treatment. I mean, I don't know what your guys' experiences are, but oftentimes we know about family members who really want to get their loved one into treatment, and we focus on trying to get the loved one in the treatment, but this does not necessarily involve the loved one from the beginning. This really is focused on working with those family members. And the family members can often be really, really motivated because they have tremendous anxiety and fear around their loved one dying or having a really negative outcome. So often the family is far more motivated than the person with the substance use disorder. And that's really the goal of this treatment, is to engage them. So motivational induction really focuses on, it's kind of like the history taking session. So you're asking the CSO why they're there, what kind of attempts they've made to get their loved one into treatment. It's a very positive frame that is set in the treatment about positive expectations. One of the evidence-based tenets that people go over in this first motivational induction session is the evidence shows that when families engage in craft, 7 out of 10 of those families who have individuals with substance use disorders, 7 out of 10 of those IPs go to treatment from the family members engaging in craft. So it's basically 70% success rate, which is way better than anything else we have. So it's a very good success rate when we engage families. And those 3 goals, you go over the 3 goals, like to improve the CSO's functioning, so family members can get healthier, to reduce the IP's use, and to get the identified patient into treatment. Those are the 3 goals. And the messaging is really about you're not alone. Really helps a group modality can really help with that, because other family members can see that there are other people in their community or in the world that struggle with a loved one with substance use disorders. Often this is a taboo subject. People are not sharing it with their friends because they either have guilt and shame, or they just are really uncomfortable sharing about substance use. We basically, when we talk with people in this first session, we introduce the idea that this is very behavioral. This involves behavior change on the part of the family member. Maybe the IP will change too. We don't really know, but the family member, we're going to be asking the family member to change their behavior and learn new ways of acting and interacting with their IP. And there's another message that there is really telling family members that you can get well, you can thrive, whether or not your IP seeks treatment in the end. So that 30% that may not seek treatment, the family member can still get better. And the behavior change is a process, and it takes time, and there's sort of fits and starts, and sometimes we make mistakes. And in therapy, we're just going to kind of go over those mistakes and kind of improve on some of the behaviors that are very new to a lot of CSOs. So the next one is in enhancing the CSO's happiness. And there's actually a happiness scale that I'm going to show because it's kind of cute. So this is the happiness scale that you administer with the family member in the session, and go over kind of all of these different areas and how happy they are with the current situation. So this is the substance use. This is their family member's substance use. Like, how happy are they with that? Household responsibilities, social activities, all of these things. So it's kind of like a quality of life assessment, but they call it the happiness scale. And they can add other things here. And it gives you a really comprehensive picture of what's going on with them. If they have multiple areas that are really problematic, or if it's really just this loved one's substance use area. And then the third procedure is communication skills training. So oftentimes when we encounter family members, and any of you who work with family, there's some really dysfunctional communication patterns in families with substance use disorders, and they're doing the best they can. They're trying to figure it out. Usually there's lots of fear and sometimes anger that is driving those negative communication patterns. So it's really teaching positive communication skills. There are 7 rules of communication. And the 7 rules are: keep it short and sweet. Look for the positive. Many times family members are really very focused on, are they using? If they're using, there's like a confrontation. This is very different than the communication skills or the kind of what you're looking for that's being taught to families with craft. So looking for the positive. There's a phrase in craft that's you catch the person doing the right thing. You catch the person being good, so to speak. You want to look for positive things that the loved one, the IP, is doing. Be specific and clear in communication. Label your feelings. So these are like I statements. Offer understanding. Accept partial responsibility. And this can be tricky because sometimes family members are being over responsible, like they're feeling like they caused it. They caused their loved one's substance use disorder. But this is in communication. Sometimes I get really mad when you come home drunk, and I know that's not helpful. So that's an example of taking responsibility. And offer help. So oftentimes the IP is not interested in help from their family. They feel like their family is over involved in their lives. So this one often is a little bit nuanced, and sometimes just engaging in those first 6 is enough of a change, and offering help may come later. So the 4th procedure is a functional analysis of the IP substance use behavior. This is a pretty behavioral, common behavioral assessment, doing a functional analysis of a behavior. But this is the CSO, so the family member, doing a functional analysis of their loved one's substance use behavior. And if you can see this, this is what it looks like. They are asked about external triggers for their loved one as they understand them. They may not understand them all, but just as a starting point. And this helps the therapist understand the patient and what might be motivating to the person with the substance use disorder. Internal triggers, like what do you think causes them to drink, or what do you think they're usually thinking about or doing right before they use? And then, the drinking behavior or using, you get more information about that, and the positive consequences and the negative consequences. And this is all from the perspective of the family. If the IP filled this out, it would be different, and that's okay. But this gives us information about some of the drivers and reinforcers of the substance use disorder from the family member's perspective. And then the use of positive reinforcement. So oftentimes family members are really engaged in a bunch of negative reinforcement with their loved one. And so negative reinforcement is yelling, blaming, pouring out alcohol, throwing things, getting in fights. I mean, you can imagine like what goes on in families when someone is using and the family member wants them to stop. There's a bunch of negative reinforcement. They're not used to positive reinforcement. So you need to define, what is positive reinforcement? What would it look like And how on earth would I do that with someone who's actively using substances? And so it's explained as, first of all, helping the CSO think about, what does your loved one who's using like to do other than using substances? So it gets them connected to the other parts of their loved one that are outside of active use. Now, sometimes people use while they're doing things they like, but this would be identifying some things they like to do that wouldn't involve using. The other part of positive reinforcement is helping the family to know when their loved one is using and when they're not. So those external behavioral signs. Sometimes families are super attuned to this. They do not need to be taught. They can tell by the way their loved one opens the door whether they've been using or not, or the first word out of their mouth. I mean, so it varies to family. But if they need some additional information to teach them about that. And so if there are any windows where the IP is not using substances, that's when the reinforcement happens. And so that can come in the form of praise, that can come in the form of acknowledgement. It seems like you're sober today. I'm really glad you're sober today. Do you want to do something together? And or whatever the family member identifies might be reinforcing for that individual. It doesn't have to be money, although it could be gifts. It doesn't have to be gifts. It could be time, affection, praise, use of a vehicle. When we think about teenagers, oftentimes teenagers are trying to escape the family. So helping them interact with peers if they're able to be sober. So kind of rewarding sobriety behavior. Oh, I guess skipped ahead. And then the other one, number 6, is withdrawing positive reinforcement when the IP is using substances. So positive reinforcement can look a lot of different ways, and family members don't necessarily always know that they are positively reinforcing behaviors by engaging. So a lot of engagement with an individual when they're actively using or come home intoxicated is a form of reinforcement. And so really helping people not do that. So that might look like if so maybe in a marital family system where the wife has the substance use disorder, if the wife comes home and is intoxicated, the husband does not yell at her or engage with her or take care of her. He simply says, you know what? I can tell you've been drinking and I'm going to go to bed. So disengage. Now, if there are safety concerns, like the person is so intoxicated that they need medical attention, that's a different level. But I'm talking about like if the person is safe to be left alone, then the other person would really just withdraw contact with that person. It also, withdrawing the positive reinforcement also covers what we commonly think of as enabling. So the Kraft model or Myers doesn't like the word enabling, although what he describes is essentially enabling as far as I'm concerned. Enabling does have a negative connotation. But the way I talk about enabling with people is you are doing the best you can and you believe that what you're doing is helpful, and actually it's not. And so let's figure out what you can do that would be more helpful than paying people's bills or bailing them out of jail or whatever people do to enable it, cover them up, like cover up for them at work, cover up for them with family members, things like that. And then the last 3 core procedures are problem-solving training. And this is really helping people in a structured way walk through problems. So a lot of times people are defining a problem that they're trying to solve very, very broadly. So you want to do narrow definition of problems, literal brainstorming. This is usually a whole session, and there's a format that they use to do problem solving. And it should be a small problem. So the problem isn't like my loved one drinks. The problem is my loved one, when they're drinking, like takes the keys and tries to drive, like that would be, it's almost like a subset of the drinking problem or the drug use problem. And so brainstorming solutions. I can share a little bit of a case example. So a family that I was working with, it came out that they had a whole protocol when their loved one came home and was clearly intoxicated. The various family members would run around the house, collect all the keys, keep the, like, literally remove the minor children, because we're young children in the home, to a room away from, it was like a fire drill, what was described. And I was like, wow, it was literally like a fire drill. And they would do this every time the individual came home intoxicated, because they never knew if they would be really loud and kind of aggressive and scary to children, or try and get keys and drive. And so you would help the family maybe do something a little bit different there, because that is the family doing a tremendous amount of work that is very fear-based. Number 8 is natural consequences for using substances. So this is really allowing natural consequences to occur, not preventing them. Many times family members prevent them. So bailing people out of jail is a very simple, obvious one. And it can feel like the right thing to do because family members have a hard time allowing natural consequences to occur. Sometimes it makes their life harder also. So that's something to talk through, like what consequences are you willing to allow and what aren't you? Obviously, family members are not going to be willing to allow their loved one to overdose. So this is not, a consequence we want to encourage people to allow. So if there's a safety risk, and oftentimes there is a safety risk that's very real, much of the time. And so we need to think about what natural consequences the family would like to allow, feels comfortable allowing, and what natural consequences they absolutely would not feel comfortable allowing. And then that's really up to the family. But this is where the skills kind of get combined. So effective communication about natural consequences, and that people are going to no longer prevent natural consequences from occurring, are where some of the skills get combined. And then the final procedure is the family making the suggestion after all of this, so after 12 weeks, making the suggestion that their IP go to treatment. And that's really at least a session or more, so that the IP has a very clear plan of how to introduce it, when to introduce it, what language to use, have a place in mind that they would be able to get into treatment, or who they would call to be able to get them into treatment. And also, this involves planning for the IP to say, no way, get out of my life. I have no interest in that. But you don't allow the CSO to give up. So that doesn't mean that's the end. It just means that particular time that you asked didn't work. And that's okay. Like, you continue to work on how to ask, when to ask. Oftentimes, as we know, timing is important, because when people have a natural consequence that is painful, they are more likely to want to discontinue use. If they have no negative consequences, most people aren't super motivated to discontinue use. So any questions or comments? That's kind of the meat of the procedures. So there's a fair amount of evidence for craft, and I'm just going to briefly go over some of it. Therapeutic approaches for treating people with substance use disorder are most effective when family and loved ones are involved. I mean, there are a couple studies cited there, but we know that it helps. So part of our IOP program at Chestnut Ridge Center, we do have a multifamily group as part of that IOP program, and I can absolutely say that the people who bring family, and one could argue, well, is it because they bring family because they actually are more motivated for treatment, or is it that their family involvement contributes positively to their treatment? So it's hard to tease that out. But the people who bring family absolutely do better in treatment. And it actually benefits the entire group to see those family members. Last week, we've had a little dry spell on family members in my multifamily group, and one of our group members was finally brave enough to bring his girlfriend, and it was amazing. It changed the whole tone of the group. She was very positive. Her father was in recovery, so she was familiar with recovery and had clearly done some work on herself. And it was interesting to see how the other there were no other family members, how the other group members responded to her, and really the whole tone of the chain of the group became very positive. Patients often report that their decision to enter treatment was based on family influence. So we know families have a lot of leverage and a lot of power to motivate. There's a fairly large systematic review of CRAFT multimodal treatment, looking at 11 studies, including both individual and group sessions. And so that was done by Archer, and had these are some of the highest IP entry rates, so 77 and 87, and 86%. Those were the entry rates of the identified patient whose family members were in CRAFT. So there are positive outcomes for both the CSO, the family member, and the identified patient. Relationships between CSO and IP are not predictive of entry rate. So this one was looking at if there's a really conflictual relationship between this husband and wife, and the husband comes into treatment and the wife is the identified patient, that doesn't mean that she's less likely to go to treatment, that the level of conflict in the relationship was not negatively predictive of outcome. So it didn't really matter. And so another outcome is the CSO's mental health and relationship happiness improves typically compared to just being on a wait list. At 6 and 12 months follow-up, mental health and life satisfaction gains are maintained even after treatment ends. So that's definitely pretty impactful. And then for the identified patient, treatment entry outcomes, treatment entry is increased for identified patients and families affected by either alcohol or drugs. It doesn't matter. It really works for both. And for CRAFT, it's twice as likely for the IP to go into treatment compared to like control or treatment as usual, like other regular family therapy or regular individual therapy for a single family member. I always like to highlight, it's very important when we work with families to understand their cultural values. We cannot recommend behavior change that runs contrary to people's cultural values. We can't ask them to do stuff that they're unwilling to do. That's not going to be good for our relationship with them, and it's not going to work. So we want to make sure we understand the cultural context of our family, whether that's that they are of a certain ethnicity or religious background, or even Appalachian culture versus a different kind of culture. And allowing patients to share that with us, not assuming that we know that means in the context of behavior change and substance use disorders. The other nice thing about CRAFT is you can do it in parallel. So the identified patient can be in a different treatment and the family can be in CRAFT. The identified patient can join the CRAFT intervention as well. Or you can do CRAFT and then you can do another form of treatment. Obviously, the idea is that you do CRAFT and then the IP goes into their own treatment. But treatment with the family member can continue after the IP goes to treatment. While it's not part of the 12-session model, I think it's really important because there's all kinds of reconfiguration in the family when the IP gets sober. Lots of stuff has to change and is different when that happens. And this is not specific to CRAFT, but CRAFT talks about this. the idea that family members become ill themselves, and that's part of what they need treatment for. Introducing mental health and trauma language to the CSO and assessing for mental health symptoms in the significant other, including all of these. And then the benefits of including families in treatment is really that they have leverage that us as treatment providers, we don't necessarily have. We have all kinds of information about the individual's substance use that we don't have. I mean, that's the other thing. I learn it when family members come to family group. I often learn a whole bunch of information about the individual's use, whether it's their history or different interactions in a family or consequences that I didn't necessarily know because I hadn't been told. Changing family system behaviors to support continued abstinence instead of those negative reinforcers that keep that negative cycle going, and extinguishing family members that reinforce use. That they're doing inadvertently, it's not like they're trying to be difficult. Family members just don't understand how some of the behaviors actually reinforce the use. The classic is kind of like the partner comes home from work and is intoxicated, and the other partner, the CSO, immediately jumps on them and starts screaming at them, and they're like, okay, this is why I use, you're such a fucking bitch, let me leave and get the hell out of here because I can't stand to be around you because all you do is yell at me. Like that is kind of a reinforcing cycle, and in that moment usually the spouse feels like, well, I need to provide a punishment for their use. It's my job to provide a negative reinforcer. So when they come home and they're intoxicated, I get mad at them. And the person with the substance use disorder says, why would I come home to this? You're why I drink. Many times people with substance use disorders will say that to their family members, and the family members believe it. And that's part of the family member believing that they caused the problem. Preventing substance use disorders from occurring across family relationships and generations. So I love, when I work with people with young children or people who haven't had children yet, one of the things that feels incredibly rewarding is the idea that I am preventing a young child from having to be exposed to active substance use, and that makes it all worthwhile. Promoting healing in all family members, recognizing that is necessary, that healing in all family members is necessary for the family to be well, and really harnessing and highlighting the family's strengths. So all reasons to include family members in treatment. These are the stages of family recovery that we think about. Active addiction, this is when the CSO can come into treatment with or without the IP. And the transition would be when the IP goes to treatment, on or about the end of the 12 weeks of the CRAFT intervention, but we can continue to work with families after the IP goes to treatment. So this is a summary. I don't think I'm going to read this whole thing, but this is a summary of all of the things that CRAFT can help with. And we've talked about a lot of these today. So this will be in the slides that come out. But it certainly is very behaviorally oriented, looking at changing communication, looking at changing interactions with the CSO, leading that change, and viewing things from a much more positive perspective versus feeling like the family member is responsible for punishment. Some resources for families. These are all peer-based programs for families. We the Village is the kind of CRAFT website, and when you go to that website, there's information about additional training as well if you're interested in training in CRAFT. And then there's just a couple of other resources. So I'm going to stop sharing. And any questions or comments? One of the questions that's come up in our setting, because we're going to be implementing, hopefully, kind of a little mini craft clinic is, well, how do you reach family members if your patient is the person presenting or not presenting or falling out of treatment, not being able to be retained in treatment? How do you reach those family members? And so I believe we can actually build in some creative ways to do that, including, I mean, you could build into your intake process. Are there any family members who are supportive of your treatment? If you feel like treatment is not helpful for you, you could give them a flyer to give to their family. You could say, you can have them sign a release to reach out to the family, especially if the person, you can bet that if a person drops out of treatment and they are connected and involved with family, obviously we know that some of our patients have burned those bridges and they don't have supportive family, but if they are connected and involved with family, they will have a family member who is like, oh my God, what are you doing? This is a disaster. I don't know what to do. I'm freaking out. And that family member would benefit from help. And if we could reach out to family members, potentially we could have be able to help them. Certainly, community centers. I mean, there are all kinds of ways to reach out to families that we have to be creative about. Our healthcare system is not set up to treat families. I talk with the therapists that I supervise all the time who say you get you get fewer RVUs and lower reimbursement when you work with a family, and it is so much more challenging. And so our healthcare system does not incentivize or really organize around trying to help family systems. But I believe that would actually improve outcomes for our patients if we did get families involved. So is anyone actively treating families? A lot of people showed up, 42 people. So I'm thinking you guys, it's a bigger group than normal for a reason. Any particular curiosity people had, or if you actually do work with families? Or what is your access to families in among the people that the identified patients that you work with?
That was going to be my question, Laura. What kind of access to this do we have any information about that across the state and people accessing this currently?
No, other than we have like 2 licensed family therapists in the state of West Virginia or something insane like that. So we have very few people trained in family interventions. Now, you can do family interventions if you're not a licensed family therapist. So people are doing interventions with families. But part of the problem is we don't have a lot of people trained in family interventions. So I'd be curious. I'd be curious like what the Medicaid data is, like how many family therapy sessions, or what the other kind of insurance billing data might be about frequency of family sessions happening. And then you would have to drill down. It's hard to, I don't know how you would drill down to who among those are coming related to substance use disorders.
Hey, it's Marianne. When you suggested, when you were talking about getting referrals for family members and how you do that, I'm wondering if reaching out to local recovery communities would be really helpful, because I can't tell you how many people in recovery get questions from my family members really struggling. What do I do? And the first response is, well, you need to get some help. So I'm wondering if that is something that you guys are planning on doing.
Yeah, I'm open to suggestions. We haven't really started this yet, but it's potentially building, and that is the thing that we're kicking around. Well, how do we access family members and maintain HIPAA? So I'm open to suggest. I mean, I don't know, Marion, when you think about, can't really be handing out treatment flyers at meetings or asking people to do that. What were you thinking?
Even if it's just something that maybe contact with like AA and NA both have like cooperation with professionals committees and treatment and institution committees, H&I, and
Yeah.
so contacting those local communities and making them aware, those district chairs, and making them aware that, hey, this exists, so that maybe they could pass it on in even in meetings and say, hey, if anyone has any interest in this, this is an opportunity for family members that they're starting up. Because personally, that's typically the question I get is, how can I help my family member? And what I want to do is, the first thing I always say is, well, first of all, I think it would be really helpful if you go to Al-Anon. And so having other options available to me, like, hey, I know this program that might be really helpful. And just like word of mouth kind of that way, or even having a pamphlet. Hey, who knows, that could be set up with the other pamphlets at meetings, just so that people would know where to refer people. Because that's honestly the question I get the most is, how do I help a family member? It's not somebody coming up and saying, I need help. It's, what do I do as a family member?
Yeah. 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 I think that's a great idea. So I'm open to suggestions, and I think it's great to share with the rest of the group. Thank you.
Sarah Life, I had commented, even connecting with crisis intervention providers to let them know when that or this program exists.
So Sarah, when you say crisis intervention providers, who are you thinking of specifically?
I'm thinking of the quick response team, or just even like the crisis hotline people that go out with that help with this stuff. Like, let's say that, the client's intoxicated, and then, there's not much you can kind of do in that situation. And then, it kind of leaves that vacuum if the patient's taken off to treatment or anything like that, even, maybe a night in the drunk tank, like sitting there and saying, okay, now there's this hole for this family, and they're kind of shrugging their shoulders. Now what do we do? Even making sure that they have access or, knowledge about this clinic when it gets up and going.
Thank you.
One thing to point out, I think from like a medical perspective, generally, especially in the psych realm, it's largely frowned upon to treat family members. It's tricky. At least that's the way that they taught me. I've kind of out of necessity had to treat some families, but I wonder if like talking to trainees that not necessarily always treating families, but you tend to focus on individuals, almost excluding other people as a means to an end or whatever. To say, it's sometimes it's necessary, and also to think about families and treatments, and they tend to get sucked into care, but a lot of times they'll ask for help, and you're like, sorry, I can't treat you or whatever. It's interesting from like a medical side, I guess, considered.
Yeah, we have lots of rules around boundaries, and for good reasons. And yet, so I've had the experience of, and really the privilege of several families who have had family members who have died, who were under my care or recently under my care, or that I treated at some point, approach me and say, can you do grief work with me, because you knew my loved one, and I really want to work with someone who knew my loved one. And some of those are from overdose, and some of those are from suicide. And I feel like it's wonderful that they somehow knew how to get in touch with me. And some of those were members who had family members who had participated in IOP, and later on their loved ones had not done well and had died. And then they circled back to connect with me. But I think, yeah, figuring out creative ways to like make connections with families, and that may look really different depending on what community you're in. Rural communities might be much easier because often the family members because it's a small community and everybody knows each other. So it's like a balance between how do I preserve confidentiality and boundaries while helping as many families as I can.
I know that, and this is sort of aside from the treatment part of that, as a peer recovery support specialist, and our peers often work with families uh, before individuals are actually ready to go or agree to go to any kind of treatment or stop any type of substance use. Um, we can provide support to those families the same way that we would to the individual themselves, and connect those families with those resources, such as Al-Anon or whatever the case might be, that we have access to. Um, and that sometimes leads to that individual, uh, eventually deciding to make that change and to get help for themselves.